Assalamu alaikum. Now I would like to discuss about autosomal dominant polycystic kidney disease or polycystic kidney disease. Okay, uh, before jumping into this, look at this picture. Look at this ultrasound. In this ultrasound, what we are seeing in this ultrasound, this area is spleen and this is the renal stone. This one is the renal stone, and these are the renal cyst. This one and this one is the renal cyst. So this is spleen, this is stone, and this is renal cyst. So looks like polycystic kidney disease. For polycystic kidney disease to happen, if age is more than 15 to 39. If age is more than 15 to 39, three or more than three unilateral or bilateral kidney cyst is enough to say it is PKD. For age 40 to 59, two or more than two cysts in each kidney, and for age more than 60, four cysts in each kidney. And in a patient without a family history, the diagnosis is made if there are more cysts, if there are more than 10 cysts per kidney, then we can consider is as polycystic kidney disease. I'm not going into the simplified things. I am just diving into the main things of the PKD, polycystic kidney disease. So when you find an ultrasound, then how will you tell the patient that it is polycystic kidney disease or it is ADPKD, autosomal dominant polycystic kidney disease? If there is with family history, if there is without family history, so that is the point. And CT scan is more sensitive. We know that CT scan is more sensitive where we can found enlarged kidney with innumerable cysts. Okay, if a patient with PKD, polycystic kidney disease comes, patient comes with flank or abdominal pain. There may be hematuria due to cyst rupture into the renal collecting system or nephrolithiasis, like uric acid stone due to acidic urine. It can come with hypertension and polyuria and polydipsia. Okay, and as a complication, it can cause intracranial bleeding. Okay, I'm looking at this box. So clinical feature, most patient asymptomatic until age 30 to 40. There may be flank pain, hematuria, hypertension, palpable abdominal masses usually bilateral, and there may be CKD, chronic kidney disease, and extrarenal features like cerebral aneurysm. There may be hepatic or pancreatic cysts. So intracranial aneurysm, hepatic or pancreatic cyst, cardiac valve disease, and aortic root dilatation, mitral valve disease, cardiac valve disease like MVP, AR. There may be colonic diverticulosis and ventral and inguinal hernia can happen. Okay, so diagnosis ultrasonography showing multiple renal cysts. I have told you according to the age relation and management aggressive control of risk factor of cardiovascular and CKD AC inhibitor preferred for hypertension, hemodialysis, and renal transplant for ESRD. ESRD. Okay. Now look at this question. A 35-year-old woman, there is hematuria, blood in the urine. Today, she has been working in the yard for 2 days, creating new garden. Positive for recurrent bilateral flank discomfort. Okay, she has hypertension, pulse, BMI high, BUN creatinine is higher. There is hematuria, RBC on the urine study. So, flank pain, hypertension, hematuria, age over 30 looks like polycystic kidney disease. So, I have read all the things. So, pol- uh, so early in the disease process, patient also develop urinary concentrating defect, evidenced by low urine specific gravity on urine analysis, low urine specific gravity on urine analysis, likely due to renal tubular dysfunction. In effect, mild nephrogenic diabetes insipidus is created, resulting in increased vasopressin level. The high vasopressin level may encourage the renal cyst. High vasopressin level may encourage high vasopressin level may encourage renal cyst growth, and tolvaptan like ADH receptor antagonist have been shown to slow the ADPKD progression in some patients. Other treatment ADPKD mostly supportive and involving minimizing the risk factor and worsening CKD. So for treatment, for management of the polycystic kidney disease, we need AC inhibitor or ARB. It is a preferred treatment due to inhibitory effect on the RAS and may also slow cyst growth. And low salt diet, less than 2 gram of sodium per day, helps control in intravascular volume and blood pressure, preserving renal function and suppression of the ADH. ADH stimulates cyst growth. ADH actually stimulates cyst growth. ADH levels reduced with high fluid intake, more than 3 liter per day, and inhibited using tolvaptan and inhibited using tolvaptan. Okay, so there is another variant like ARPKD, autosomal recessive polycystic kidney disease. Polycystic kidney disease may be ADPKD, ARPKD. Less commonly, autosomal recessive polycystic kidney disease affects just children. Autosomal dominant or adult polycystic kidney disease is dominant and recessive for the children. In it may come with Potter sequence like pulmonary hypoplasia, oligohydramnios, twisted face, twisted kidney, twisted kidney. There may be pulmonary hypoplasia. There may be uh, limb deformity. These can happen. Okay, and this is uh, this is the polycystic kidney disease. The most common cause or the most common type of polycystic kidney disease is autosomal dominant polycystic kidney disease. Like PKD1, it's 80% and PKD2 is 15%. PKD2 is 15%. So for remembering the PKD or for diagnosing PKD, we need clinical feature like flank pain, flank or abdominal pain, hematuria, hypertension, polyuria, polydipsia, and there may be other features too. Mm, there may be external features too. And for diagnosis, we can do ultrasound, we can do CT scan. Is the CT scan or MRI is more sensitive. And for treatment, we can use, we should control, we should control hypertension by giving ACE inhibitor or ARB, which is the drug of choice. We can use a tolvaptan, which is an ADH antagonist, because ADH actually stimulates the renal cyst to grow. So ADH antagonist. And sodium, uh, we should intake less sodium, less than 2 gram per day, and intake of more and more fluid, like more than 3 liter of fluid per day. So that is all about ADPKD, or polycystic kidney disease. It's a very important topic. Hope you enjoyed.